Hello, welcome to this Rural Doctors Webcast. I'm Simon Stokes. Thanks for joining us. This program looks at opioids. Later in the program, we'll speak to Dr. George O'Neill about how his recovery program treats addiction to opiates and other substances. And we'll also hear from pain management specialist Dr. Stephanie Davies. But first today, we're joined by Dr. Max Majedi. He spoke with Dr. Olga Ward about his approach to opioids, their alternatives, and how to take in social and cultural, physical and even physiological factors when approaching chronic pain.
Max, welcome to the program.
Thank you.
Opioids, quite a difficult subject, particularly for general practitioners. Can you tell me how they actually work?
All right, so opioids, and anyone who's interested in history, you know that it's been around for over 3,500 years, so as far as we know, and there's records of it being used in all sorts of different ways, going back to Greeks and Hippocrates, and they actually had access to different elixirs they used to make and it used to relieve pain, relieve anxiety. They used to use it as a lotion. They used to use it all sorts of ways. So it's been around for a long time. It comes from poppy seeds originally, and if anyone wants to try it, you need to have 3.5 kilograms in one go of poppy seeds, and you may get some narcotic effects. So don't recommend it, but there is out there if you go, especially go to Tasmania. How do they work? So the science behind opioids that, and I think everyone knows, that it works on mu receptors. So it's a mu agonist. What is a mu agonist? Mu is a ligand-gated channel, and is a G protein coupled receptor that when you activate it, it hyperpolarizes the nervous system, especially the sensory nervous system.
So then it becomes refractory and the pain impulses don't go through, is that the idea?
That's right. In a simplistic term, it makes the discharging of the nerve harder because you increase its polarity. So the action potentials are less likely to develop in a very simple way. So it's an electronic channel, effectively.
Yep. So where are the receptors? Are they all central or all peripheral, or are they everywhere?
Everywhere. So the thing with mu receptors, or if you like, opioid receptors, which are, there's effectively many, but the ones that mainly we focus on is mu, delta, and kappa. There's also 2 or other 3 which behave in the same way, but they're more experimental. We don't know enough about them. Where they're actually everywhere. They're not just in nervous tissue, they're in the immune tissue, muscles, they're in central nervous system, they're in our homeopoietic system, so they're everywhere.
So if you had somebody with a big slash on their arm and you dripped morphine into the slash, would you get some analgesic?
Potentially, you could. And there are situations where opioids used peripherally actually has an effect. For instance, we put, when we do nerve blocks, we put buprenorphine with a mixture. And buprenorphine in particular has a very high affinity for mu receptors. And therefore, if there's a few mu receptors around the peripheral nerves, it will attach to them and stop action potentials being developed from periphery as well as centrally. So, yes, there are mu receptors around the place.
Okay, so what is the problem with putting patients onto, like I certainly understand using opioids for somebody with a fractured femur. Why do they become tolerant after a while, and what's the big problem with them taking it long term?
So if you go again to the basic science of it, the issue with the mu receptors, opioid receptors, is that when you stimulate them too much, they start behaving in a way that most receptors in our body tend to do. They lose affinity for the actual ligand or the drug, which is morphine or opioid. So when you lose affinity, it means you need more and more to get the receptor to behave in the way you want it to.
All right, and this happens to drug addicts as well. I
to
suspect
all
if
of
they
us.
shoot up something, they need a bigger dose to get the same
You don't have to be
effect.
addict. It happens. So you and I start taking an opioid for whatever purpose, and you have a measure of its effect. The effect will drop with time, and every opioid is different, and every individual is different depending on their biological makeup and their genetics. So it goes in the field of pharmacogenetics that we as human beings or as living entities, all behave very differently with different chemicals. And there is a huge field of science behind that, and there's a lot of stuff that happens as we go through our life as well. So genes do switch on off, and these receptors do change depending on environmental forces. So there's a lot of science that which we haven't got access to because it's too big, and gradually we're learning how these things work.
Yep. Now, I had one patient who has very chronic pain, and he was sent to have a ketamine infusion, and I understood this was something to do with resetting his receptors. What's happening there?
Ketamine, again, anyone who grew up in the 70s, which is not me, but it's an interesting chemical. So ketamine was, as most people know, it's German developed, and it's actually it was heavily used in the Vietnam War as an anesthesia. Ketamine is a very interesting chemical because it binds to NMDA receptor. And it's the same sort of chemical as LSD, effectively. It's a form of LSD. The NMDA receptor is throughout the nervous system, and it couples effectively to mu receptors. What NMDA receptors do then, through a number of mechanisms, it resets how the cell behaves in terms of its relationship with mu receptors. So by using ketamine, you can actually reverse the process of tolerance.
So then you have to drop their opioid dose.
Yeah, so you actually
afterwards.
allow them to drop their opioid dose without actually causing, in a very simplistic term, electronic mishap in the nerve.
So say we could accelerate a patient's doses over time while their mu receptors become less susceptible to their opioid. What's actually the problem?
Effectively, you have a system that becomes unresponsive to a chemical that works throughout the whole body. So whilst you're introducing a chemical trying to achieve analgesia, and that system becomes tolerant, you still got an increase in doses of a opioid, which is causing harm in other places.
So the things like the constipation and the drowsiness and the other side effects, they don't show the same tolerance that the pain receptors show?
Yeah, it's all very system specific. So, and as a general rule, when you start messing with a biophysiological system by introducing a foreign chemical, you're always in the danger that if you like, you're holding a big gush of water in a dam, and if you suddenly remove that drug, then you have this system that's going to go overload and cause significant harm. So by needing more and more of the ligand, you're actually causing significant changes in the nerve cell. Also, we know that unfortunately these chemicals activate the inflammatory nerves, or the interneurons that keep the whole nervous system going. These are the glial cells and astrocytes, and they actually activate those in a bad way. So there is good evidence that with increasing dose of opioids, it actually encourages a form of neuroinflammatory process where, by releasing a lot of inflammatory markers from glial cells, for instance, you can actually damage or inflame the nervous system, and that's not a good thing.
Yeah. So obviously we try not to put patients onto long-term opioids, but what are our alternatives for patients with really significant chronic pain?
It's almost, to answer this question properly, you got to look at what is chronic pain. I mean, it's in its broadest term. I'm fortunate that I can go to third world countries and developing countries and look at what happens in pain. So let's look at the lumbar spine pain model. I just recently came back from Mongolia, and I thought these guys are quite tough, but interesting enough, they have a lot of issues with chronic lumbar spine pain. However, you don't see the dysfunction that we see in Western world. They still just get on with it, but they rather not be in pain. And it's interesting because for instance, chronic pain to them is just normal part of life. They don't like taking drugs, but they have something that can actually alleviate the pain so they can work harder. You go to a place like Southeast Asia or Cambodia, having back pain, chronic back pain, is actually seen as a good thing. Means you are working hard, means you are a good person. So chronic pain has a lot of social connotation around it. So what is chronic pain? Chronic pain, in a very simplistic term, started in some form of acute process. You don't just wake up one day with chronic pain. There is some form of acute process which is not always necessarily an organic process. It doesn't necessarily start with a broken leg or a disc or some sort of operation. It can actually start in a non-organic when the patient who's susceptible to anxiety and depression. But you can always combine a non-organic and organic process together, and that's when you get more likely development of chronic pain. So when it comes to someone who actually has the definition of a chronic pain, as in they have ongoing pain in a particular part of the body, it's not necessarily a process where there is an ongoing damage. In fact, in most cases, there's no ongoing damage to the body, but it's the combination of central nervous system and the peripheral nervous system being at a state of heightened activity.
Yep. So kind of you've sensitized the spot.
Yeah.
And your brain continues to think that there's something wrong at
Not
the
only
spot.
think,
Or-
but if you look at the evidence through functional MRIs and PET scans, it's not thinking that you got pain, the pain is actually there.
Yep.
But the pain
there's nothing
generator
pinging it.
may not be all through an organic peripheral process. And that's the thing that makes chronic pain very fascinating, interesting, but also extremely hard to treat. So then we look at our tools. Unfortunately, through our training, through obviously the tools available, through big pharmacological companies, most of our tools are heavily oriented towards drugs.
So if you're trying to assess one of these patients and work out what would be the best combination of things to do for them, how do you assess them, and then where and when do the opioids come in?
Opioid minimization is the mantra. So it's not good being on opioids. It's not if you can avoid it, it's better. Doesn't mean you don't have any opioids or you don't have an opioid for a small period of time. It just means that if you condemn somebody's life that they need opioids just so they can get up and have a shower or watch TV all day and not work, that's not the point. That's not a good thing. So being on opioids long term is I think a failure for someone who's got 20 or 30 years of life. Because long term we know that there's no evidence that they work. Also the evidence is that they stop working usually about 8 to 16 weeks. And this is the data from Scandinavian studies. So being on long-term opioids is really a failure of the system. So where do you assess is you actually have to work out where the pain is coming from. So you got to work out how much proportion of the pain is organic, as in there is an actual damage to body, and how much of it is non-organic, how much of it is neuropathic, where there is the nervous system heightened, and how much of it is the patient's perception of what the pain is doing, and what is the dysfunction that goes with it, what I call the non-organic component. The reason for that is that the opioids work really well for the organic component, but there are very poor treatment strategies for non-organic. The non-organic is all the psychosocial stuff that we refer to. By giving a patient that's got a non-organic driver of the pain, opioids, you are effectively giving them a chemical that numbs them, but doesn't actually encourage them to deal with the actual issues that's driving the dysfunction that goes with pain. This can potentially lead to dependence, and dependence finally to addiction. So this path has been demonstrated in a lot of models, and that's why introduction of opioid has to be done with care, understanding how they work, and what opioids are giving for what problems.
Yep. So what are your alternatives for these patients with
There's
very
actually more
significant
alternatives. There's actually a lot more alternatives. Think of pain management as a really nice cake. So that's what I do. It's like, most of us are happy with a really nice cake and we like a little bit of icing. If you reverse that equation with a massive chunk of icing and a little bit of cake, the cake tastes disgusting. But if it's very sweet, then we get a high and we say, great, fantastic. So pain management has to be in the same way, that if you got a very nice cake, the opioids actually do a lot of good as a thin layer. But if you reverse that, it's not good. So what's the cake? Let's look at the cake as, in a very simple term, as pharmacological and non-pharmacological. That's the biggest tool. We know that our non-pharmacological tools can be very useful, but not always appropriate for every patient, depending on the age, pathology. But the non-pharmacological tools, broadly, you can look at conservative, non-interventional, interventional, and surgical, where you actually alter somebody's anatomy. In the pharmacological front, you got opioids and non-opioids. I think for the purpose of this talk, let's look at the non-opioid pharmacological. So non-opioid pharmacological, you got everything that addresses the different aspects of pain generator. So if you got a neuropathic component, we have a lot of tools in that. We got gabanoids, gabapentin, pregabalin. We got clonidine, which actually has an anti-sympathetic activity, reduces anxiety, actually helps the descending pain pathways. You got all the SSRIs and SNRIs, and tricyclics, which also enhance the descending pathways. You got specific agents that work on spasm, for instance, dantrolene, which is an antispasmodic.
Gosh, I haven't seen that for a long time.
It's a very old drug, and we've got to remember, why don't we use the good old drugs? We always go for the ones that the drug companies are pushing on to us. And then you got other agents such as magnesium, which is not a drug, or it is a drug because you're giving it to a patient that actually has reasonable levels for antispasm. And then you got a whole other peripheral drugs that are what I call hybrid, which is tramadol. They got mu effects, as in opioid effect, and non-opioid effects. And the new one, tapentadol, which is in the same category, has a mixed effect. Then you got ketamine, and also at the end, I'm not going to emphasize, but you got drugs like benzodiazepines, which is a myriad of them. Again, they have the same problems as opioids. They cause tolerance. Don't forget the anti-inflammatories, which is a lot of them. They deal with inflammation, and steroids, which also are analgesic because they address a particular aspect of pain generation. It becomes a bit of an alchemy.
It sounds like there's an awful lot of drugs with an awful lot of intercurrent side effects. I'm just imagining a patient on, say, pregabalin and clonidine and magnesium and. Are they doped out of their mind?
Well, they can, if you don't target what's causing the pain. So a lot of this stuff becomes familiarity with the pharmacology, knowing the patient really well, as in age, their physiology, etc. So we got to know what's happening in them and what is the pain generator. So, for instance, if a patient comes in very distressed and you miss the fact that the actual pain generator is very much non-organic, and you give them these drugs, they will be very dopey. But if there is a significant organic pain generator, think of it as if you like, as a computer. If it's generating a lot of electricity, then you can throw these in and not have them dopey because you're having a lot of input from the nervous system.
Okay, so I'm thinking about quite a number of my elderly patients who've got, bones rubbing on bones, and they're too frail to look at a hip replacement.
Exactly, it gets very difficult. And in fact, a lot of our elderly clients don't tolerate any medication. Hence now we are, with appropriate training and skills, we are relying more on interventional pain control.
So things like nerve blocks.
Nerve blocks, joint injections, rhizotomy, and there's using Symvist, for instance, for knees, for patients that have this, and also procedures which modulate or change the way the nerve behaves around the pain generator. And this is purely because a lot of patients don't tolerate anything.
Now, just for my information, when Symvist first came out, it was available on private prescription. Quite a lot of us put quite a lot of Symvist into quite a lot of knees and had very variable responses.
That's right,
How good is it really?
Well, that's the thing. A lot of these tools, it's unfortunately it's a risk-benefit exercise, and we know Symbix is quite safe, but it's not for everyone. So when it comes to actually delivering a treatment, you got to look at all the options and say, okay, the harm minimization and treat. If it fails, okay, it's failed. Being realistic and open and not going with the glossy drug company pictures, which is, so having a bit of skepticism about what they're pushing and selling is important. We use it on patients after certain things have failed, and knowing that this may fail, but at least it's not going to cause further harm.
So at least we can tell the patient, look, let's have a red hot go, and might have a 50-50 chance of
that's right.
doing something, but if it does nothing,
great.
it's not a problem.
If it works, we do a trial. If it works, great. If it doesn't, at least we try something that's reasonably safe.
So getting back to our opioids, why would somebody choose an opioid analgesic? And if it looks like the patient might need it for a reasonably long term, what kind of order do you stack them in?
Yeah, so opioids, if you like a simple saying, choose your opioids wisely. Opioids is a big group of drugs, and they all behave very differently in different individuals. Now, broadly, again, this is sort of teaching med students and scientists, you divide them into synthetic and non-synthetic opioids. So the synthetic ones are your methadone, pethidine, tramadol, tapentadol, buprenorphine, remifentanil, alfentanil. All this stuff is manufactured in the lab using different chemicals, and non-synthetic is all the poppy seeds, which is oxycodone, codeine, morphine, hydromorphone. Are there big differences between them? There is, but effectively they all do the same thing, but however they got different kinetic properties, as in how they behave in the body, which makes them useful for certain things and not useful for other things. So how do you choose what opioids and in an acute sense, and how do you choose long term? That's a very difficult question, and if you talk to 1,000 practitioners, you will get 1,000 different answers. For very reason that I suppose doctors are reasonably fickle creatures, and we just want to see the patient happy. If you talk about happiness, there are opioids are more likely to make a patient very happy for the wrong reasons. And these are generally the opioids that are heavily modulating the dopamine centers in the brain. So the ones that modulate the dopamine centers are simply morphine, oxycodone, hydromorphone, fentanyl, pethidine. And so you can have a very happy patient, good pain control, but the euphoria or the comfort and the brain numbing effect they're getting is not conducive for long-term management. In the wrong brains, these drugs can develop dependency and addiction. How do you pick these patients? Extremely hard, very difficult to work out who is who. Generally, patients that are, their pain behavior is driven heavily by anxiety, and anxiety is a big component, are the ones that are more likely to become dependent on these chemicals. So it's important that we put that into the equation before prescribing, very important. And definitely we see it on day-to-day practice when I do the rounds in acute pain and chronic pain on the wards, that the patients that are highly anxious keep reaching or demanding for oxycodone, for instance. The ones that are not anxious are quite happy and well managed on buprenorphine, for instance. And these drugs are very different how they behave. So when it comes to prescribing, you got to know the patient, the pharmacology of the drug, and how the drug behaves short-term and long-term, which is a lot to ask for most practitioners. That's why we have a system of checks and balances, specialists, etc.
Yeah, so I mean, I think for many general practitioners, or certainly for some of us, one of our patients whom we will know to be quite an addictive personality or a recovered alcoholic or whatever, and they'll go to hospital to have, I don't know, cancer surgery or something. Of course, they always come home on oxycodone.
Yeah. So that's the question of...
Then we've got to get them off it.
Yeah. The couple of things I said about oxycodone, why it has had a success, if you like, $9 billion worth of success over 8 years worldwide, is that it heavily modulates the dopamine centers in the brain, specifically nucleus accumbens, and where all our cravings and satisfaction centers are. The other interesting thing about oxycodone as a chemical is that it is actively transported past the blood-brain barrier. So 5 milligram will hit your brain as quick as 20 milligrams. It's actually equilibrates in the brain tissue much faster, or equal as fast as heroin, which is diamorphine. So it's a very interesting chemical in terms of what it does to the other centers of the brain in terms of its modulation of the brain. Hence, it's been a very satisfying drug for a numerous number of people, but not for the right reasons.
Yeah.
So you are right. In terms of starting someone on chemicals from specialists, they need to be more cognizant of what happens at the cold front, which is the general practice. So it's all very well for us to throw drugs around left, front, and center, but we need to take more ownership of what happens after. And this is what me and a few of us have been trying to push for: better prescribing practice and better education of patients, which we are doing actively, and talking to the general practitioners and using the patients as a form of education portals. Because the patients are the best educators, because they can transport between us and the general practitioner. And if we talk to the general practitioners, then that closes the loop. And this is happening more and more.
Yep.
Definitely the college is pushing it. The Faculty of Pain Medicine is definitely pushing this.
So patient comes home on oxycodone, looks like they're getting hooked. How do I switch them to something, and what do I switch them to?
So I think it's a question of assessing the organic pain generator and looking at is there still ongoing organic pain generation, and that depends on the type of surgery, what's happened, complications, etc. So the whole spectrum of being hooked, which is actually become dependent, tolerant, addicted, to actual pain management. Given that oxycodone in a lot of patient cohorts can potentially cause these problems, it's best to move away from it as soon as possible. How do you do it? You rely on chemicals that are less likely to cause euphoria and work on nucleus accumbens, and now we have a lot of them. So if you can manage the patient with a small dosage of combination of tramadol, tapentadol, buprenorphine, clonidine, Lyrica, you're much better off, because you are addressing the different aspect of pain generator, but not relying on a chemical that actually makes patients feel good, but for the wrong reasons.
Yep.
How do you do that? That's very difficult to answer in this scenario, but you got to use a patient is case by case basis, based on their age, physiology, comorbidities, etc. But in a very simplistic terms, what I teach the registrar is that you want to have a default that is less likely to cause problems downstream. So we are now discharging patients, for instance, on Norsepan patch, tapentadol, small quantity of buprenorphine sublingual from hospital, and other adjuncts with time frames. And we also tell the patients what each drug is and explain to them and ask them to get further help if the pain continues, and not to just take more chemicals. Also creating services, the perioperative service, for instance, when patients go home after a big operation, that there is some sort of perioperative service so they can call in onto if the pain is not controlled, purely because there may be a complication or there may be other issues developing. These are work in progress, and by teaching the general practitioners, I think we can tie the loose ends in terms of patient going home with lots of drugs and not knowing what's going on. Oxycodone obviously being the most problematic, as it's been on media, and there's been few high-profile deaths. But take oxycodone away, morphine will become a problem. However, I just want to say one thing about drugs that are hard to kill people with, which I like. There are certain drugs that if the patient overdoses, or if they try to abuse it or misuse it, they're less likely to come to harm. Doesn't mean they won't try, doesn't mean they're not going to sell it or do wrong things with it, but they're less likely to come to harm. And these are simply gabinoids. It's very hard to cause harm with gabinoids, far harder than oxycodone.
Good, yeah.
Tapentadol, there's already been several, even with this state of accidental overdose, should I say, or recreational overdose, and nothing has happened. And the data that's coming from US is that in a case of overdose is not as much problem as other drugs. It's still problematic, but not as much. Tramadol.
Yep. You still reverse those with naloxone if you're seeing a patient with an acute
you can
overdose?
partially reverse them, but the overdose they get is non-opioid based overdose, non-mu based.
Yeah.
So it's not necessarily respiratory depression, it's more of a central nervous system effects. So for tramadol overdose, generally what happens, you can fit.
Yeah.
So it's not opioid related. It's a non-opioid component that causes some of the harm. So in terms of, you're never going to have a perfect system, but these chemicals cause less harm. Even paracetamol is quite dangerous, obviously. Even anti-inflammatories at a high dose are very dangerous. We often see problems with anti-inflammatories that are mixed with codeine, for instance. Patients tend to overdose accidentally on dose because it makes them feel good.
Yeah.
So there's a lot of these things that we're trying to tie the loose ends so that if the patients get desperate because of their pain, or they have a tendency for addiction behavior, or they just, I'm not sure why people actually take some chemicals, they just want to feel differently, they don't come to harm, and that's the best you can do.
Finally, Max, country doctors who are trying to manage the patients that have been discharged from Tertiary Palace of Healing and are extremely remote from you.
Yes.
How do they get information or work on some of these things without the patient having to travel and also without them having to wait 6 months to get into the pain clinic?
This is again a failure of the system that hasn't I suppose, engaged interdisciplinary practice. I know there's a massive void in this area. What we're trying to do to create a better link is early access through phone calls. So there is a pain specialist on call 24/7 in St Charles Gardner Hospital. So if there's a desperate situation, the switch will put a practitioner through the phone. And it's good that I'm getting more phone calls for advice. And I think that's great. If the practitioner is not available, they can leave a message, and we always get at least our senior nurse to ring back and answer any questions. So there is access for that. In terms of access for assessment by a pain specialist, yes, that is very difficult. And I don't know if that's something that's going to get better in short term, given the health budget is not exactly expanding.
Yeah.
But if you think about it, you can't have one doctor per patient 24/7. That model doesn't work. So by educating the patients better and educating our younger doctors better, we can actually have a more long-term solution with this. Electronic scripts are on the way in. It's taking a long time, like everything else. And having clear diagnosis for patients when they leave the hospital, so the practitioner knows that there's a lot of non-organic pain generator. Also empowering the general practitioners to say no when they feel it's inappropriate. I think that's something that's really been through the 80s and 90s, this sort of pseudo-political correctness that you can't say no or you can make the patient unhappy is not a good approach. So empowering GPs to say, look, you've done your best. The patient keeps demanding this, but it's been looked at, and saying, sorry, I can't give you any more. That's it. Generally speaking, no one dies from pain. People die in pain. And we have access to emergency, etc. So if someone's in real trouble, they can go to emergency department where they are at least in a protected environment where they can get assessed for all the mishaps and all the problems and get given the appropriate pain management, not just another script for oxys or whatever the drug of the choice is. So I think these things will get better and better as we actually start communicating better, which is what's been lacking.
Max, thanks so much for joining us today, and thank you for giving us so much useful information.
Right. So it's all positive. It's just part of what it is, and we will learn and we'll get better. And I think in 5 years' time, we're not going to have these discussions and these problems as we start evolve in this science and art.
Thanks to Dr Max Majedi for his time. Dr George O'Neill is an addiction specialist and the medical director of the Fresh Start Recovery Clinic in Subiaco. The clinic helps patients get drug-free by using the sometimes controversial naltrexone implants. Dr O'Neill met with Dr Olga Ward to speak about how the implants work and why he believes they're the most effective way of getting his patients free of addiction.
You can't really climb out of addiction as an individual without the support of somebody. So nearly all the patients sitting outside this morning will be here with somebody they identify with who's in the non-using group. We almost didn't want to see the patient unless they came with their sister, their mother, their brother, the lady down the street. And it's very different to other addiction clinics because other addiction clinics promise to keep you comfortable. And we're saying, no, we're not interested in keeping you comfortable, we're interested in helping you get rid of your benzos, get rid of your amphetamines, get rid of your smoking. So we're controversial because we're not interested in keeping people comfortable.
I was living by myself and my dad kind of was just like, right, I need to get some help, and gave me a handful of brochures when I was in terms of recovery, rehabilitation. And he actually thought it'd be best if I went and did some farm work or something like that, because, yeah. So I had a look through the brochures and I was like, oh, that looks all right, that looks cool. And I saw the Fresh Start one, and I was like, oh, heard about these naltrexone implants, but I actually thought they were primarily for heroin or opiate-based addictions. But because I've been like using codeine like for many years, I thought, okay, it should help me as well. So yeah, I chose to come to Fresh Start and have the naltrexone implant. I didn't read too much about the brochure, and I found that they've got a rehab up in Northam, so I was just like, that was a bonus.
There's 80 different staff, there's people who are psychiatrists and psychologists, there's counsellors, but we do have one principle. We don't send you to the counsellors till after you've got an implant. So we change the physiology and the housing first, and the home, and then go on to start working on the relationships and empowerment and education and employment. We don't really want to see anybody unless they're willing to fill out a form with the GP to say, I want to change my whole lifestyle. So if you're a country GP and you want to sit in front of a patient, you can say to the patient, do you want to be comfortable or do you want to get rid of your addiction? If you want to be comfortable, I will send you to the next step because they know how to keep you comfortable, and there is nothing wrong with being comfortable. If they want to get better, send them down to our clinic, tell them to get on a plane or get straight down, and 10 Temgesic tablets will get them comfortable for a day, but we can put an implant in the same day they arrive, and we can have them back in your office the following day. They won't use opiates for the next 6 to 9 months.
Well, I was looked after really well at one of the recovery houses at Harborne House, which is just down the road from the clinic here. Yeah, I needed a lot of support. I just couldn't walk or anything, couldn't think really. So I was in bed for about 2 weeks and had a lot of support from the staff. I was a bit strange because also I was coming off benzodiazepines, clonazepam, which is one of the toughest ones, and alprazolam. So that was really tough, as well as because I used to use cold water filtration to extract the codeine from the paracetamol as well. So I started off, had the naltrexone one first, which was probably for codeine, and then George proceeded to give me a flumazenol implant probably about a week later, so that helped.
In terms of medicines, we've tended to concentrate on the antagonists. Antagonists are a group of molecules that will go into a receptor, block the receptor for a period of time, and then come out. There's another group of molecules which are called partial agonists. They go into the receptor, they cause excitement at the receptor. So there's a process of understanding morphine as a pure agonist, methadone's a pure long-acting agonist, codeine's a short-acting agonist. You need to understand you can take people from these pure agonists to partial agonists to blockers, And in the process, you'll actually be taking people from an addicted state to a non-addicted state. If you ever give somebody another agonist, like every time you hand out Valium, you're prolonging the anxiety disorder and you're prolonging the addiction. If you gave people no methadone, they would only inject for 5 years. And whereas if you give them methadone, they inject for an average of 20 years. So you've got to go and talk to your wife and say, why am I going to work? Do I want to keep my patient addicted for four times longer? Do I want a 20-year-old to still be an addict when he's 40? He'll have had 3 children and 2 marriages. It's a tragedy, the traditions that have been set up. Pain patients are interesting because you can give them a naltrexone implant and still put them onto Subutex, so you're getting a combination of blockers and partial agonists. And they're a bit more complicated to manage. The methadone patients, it takes us 2 weeks to get the people off methadone. We move them from methadone to buprenorphine, and then 2 weeks later we give them an implant.
In regards to can naltrexone help with meth cravings, definitely, and also being at the Northern Rehabilitation Centre, firsthand I've seen it for myself. A lot of guys had naltrexone implants just for meth, and it actually does settle them, and they do seem to come a long way. And also, I think they found that naltrexone in conjunction with flumazenol implants helps to minimise their anxiety levels. So those two combined can do a lot for someone struggling with methamphetamine addiction.
There's 2 adverse reactions you can get with implants. One adverse reaction is to take a patient on who's just been using 300 milligrams of methadone a day and put an implant in. He'll be acutely ill, and you'll stress his cardiovascular system, his respiratory system, every system. And so we titrate very carefully across from methadone to partial agonists. So that's the first group of adverse reactions you can get. The second group of adverse reactions is you have inflammatory reactions, and inflammatory reactions to pouring naltrexone into the tissues occur in about 10%, and they're manifested with itchiness. And the first symptom that patients present is to say, oh, I had an implant 12 or 15 days ago, it's getting very itchy. You can imagine that a couple of days later it's going to be red, and a couple of days later it's going to be painful. And a week or 2 later you'll actually be able to pick up fluid on ultrasound, and if you put a needle in that fluid, you'll actually pull out pus. It looks like ordinary pus, but it's never got any bacteria in it. If you can see people between day 12 and 40, if you've got any itchiness, give them 25 milligrams of prednisone a day for about a week or 2 weeks, and it'll usually settle down. You'll see 1 or 2% having some inflammatory reactions. Managing them properly is a very important part of getting people better. But the take-home message is, if you've got a heavy alcoholic, worthwhile getting an implant in. If you've got a heavy amphetamine person, worthwhile getting an implant in. If you've got a codeine user, never put them on methadone. I think you should go to jail for putting people on methadone, especially putting codeine people on methadone, because you're making their addiction significantly worse, and for no good medical reason, and with enough information to say this is a really bad medicine.
So the naltrexone gave the boost originally to subside all the cravings and stuff, but it did help. But it was a lot of hard work as well on my behalf to kind of achieve abstinence from using. But I like to think I've come a long way. Don't even really crave anymore.
We are treating a lot of people from Esperance, a lot of people from the southwest, a lot of people from the Pilbara, a lot of people from Sydney and Melbourne and Brisbane and the Northern Territory and South Australia. So 20-30% of our patients will be fly-in, fly-out patients. We've got accommodation. If people want to write down a number, it's 9388 2328. That number is useful because that'll get through to our 24-hour house where we give people accommodation, so somebody landing at the airport can look that number up and just come to our house, which is at 17 Harborne Street in Wembley. And so they'll be looked after there overnight. They usually have an implant the next day. They go back to the house the next night. They'll fly out if they're straightforward, or they go into some of our long-term accommodation if they're not. but we're certainly keen to get GPs to fly in, learn what we're doing, bring a batch of patients with them, learn how to put implants in, take the work off us. And so we're very keen to do that, but I wouldn't really want anybody doing it without coming down and doing one day's training. One day's training involves either coming on a Saturday at 10 o'clock or flying in on a Wednesday morning, just spending a couple of hours with us. But I am always looking for people who take some of this work off us.
Thanks to Dr O'Neill and indeed everyone at the Fresh Start Clinic. Now, Dr Stephanie Davies is a regular on our program and a pain management specialist. She met with Dr Olga Ward to give her advice about when opioids might be considered and where she feels they're of no benefit or indeed are harmful.
Stephanie, welcome to the program.
Great pleasure to be here.
As a pain specialist, why would someone choose an opioid analgesic, and which one would you recommend for what sorts of things?
Sure. If I can answer that two different ways,
Yep.
I'd like to go back 20 years ago. So 20 years ago, basically we had about three things as a pain specialist. We had morphine, we had Panadol, and we had needles. Sadly, at that point, even 20 years ago, we didn't understand how important things like movement was, or pacing your activity, or doing mindfulness. We didn't even know that some of the existing antidepressants like Endit were useful for pain. So 20 years ago, opiates were used quite a lot when people had quite significant pain. That is somewhat different to where we are now. So we're forward 20 years now, and we've got actually quite a wide choice of drugs, like say for neuropathic pain, which is a separate group. We've got more of the antidepressant variety drugs which can be useful for neuropathic pain. We've got a wider choice of anti-inflammatory drugs. We've got long-release Panadol. So the question really is, normally we would have tried all of these non-addictive medications and try to link those with what sort of pain the patient has. So if they've got neuropathic pain, you ought to try the anti-neuropathics. If they've got more inflammatory pain, you might have tried the anti-inflammatories, or Panadol. If their pain seems to be more related to having high stress, high worry, high fear, you would have addressed those components. But say if you've done all of that, so you've done all of the non-addictive options, and you've hopefully along the way linked the patient, say, to a good physiotherapist or somebody who's having to coach them in pacing, then sometimes you're between a rock and a hard place. And it's really in that rock and a hard place where you might think about opiates. It's certainly not the first thing you think of nowadays, although historically, if you go back 2 decades, it might have come up higher on the agenda or on the menu, but nowadays it's one of those things that we keep for sort of like when things aren't improving and when we've really covered a lot of the very straightforward angles.
And so if you're looking at adding something that's an opioid analgesic, I take it you add rather than substitute?
It depends a little bit. So normally by the time we're thinking about opiates, we would have tried several tablets. Hopefully at each point when you're trialling something, you'll try to get from the patient, has this helped the pain that we're aiming to treat? Has it given you any side effects? And are you actually able to then do more activity? So normally over a period of time, you've sort of got a list of medications that the patients are either on because they find them useful and they don't give them side effects. And so sometimes you might continue those. If there's one of those tablets which is useful but giving you a side effect, you might be swapping to something else because you're trying to find something that works equally well but with less side effects. And it's probably a 50-50 split. So half the time you might be swapping, but half the time you might leave them on what they're already on, because they're the non-addictive options. So you might be able to manage on a lower dose of an opiate, which at the end of the day, they are addictive. That's why they're S8 tablets.
Given that we've now got a range of everything from buprenorphine patches to hydromorph syrup, how do you choose what you choose?
Well, this is where I might make it easy, and I'm going to have to probably say out loud that what I'm going to say, I've developed this bias over about a decade. So it wasn't a bias I've developed just this week, but basically when buprenorphine patches came out, which is the trade name's Norspan, I think they came out guessing in about 2003, somewhere around there. And at that point, the drug companies said to us, well, the good thing, one of the good things about the Norspan patch was people didn't tend to get tolerant to them and they didn't tend to escalate the dose. And I sort of thought in my head, well, I'll see if that's true or not. We'll sort of just wait on that one and see how that pans out clinically. Clinically, they do seem to be right. So pretty much with Norspan patches, most people like my age, my size, will need to say 10 milligrams. Some people might need 15, so that's a 10 plus a 5. smaller people might only, or people who are sensitive might only need a 5 milligram, or say if you've got a little old lady in a nursing home might just need half of a Norspan, so you can cut them in half, or put an
So
opside
it's
under
actually
half
kosher
them.
to cut them.
Drug companies say not actually. The more kosher way of doing it, if you get like an opside and basically you occlude half of the patch, you can actually get it down to a 2.5. But I have actually told patients they can cut it, even though I know that's not in the in the prescribing information. And then the top dose, or the top patch currently available, is 20 milligrams, which I do have some patients on, but not very many. And there's only one patient I think who's got on 2 of the 20, so that's uncommon. But basically starting with a 10, and you can do things where you can add, like, say, give them a script for 2.5, so put 2.5 milligrams on, because it basically takes about 6 to 8 hours for it to start getting in their system, so about 8 to 12 hours it's starting to work. But the Norspan patch continues to go up, so it plateaus about day 2, day 3. So say day 2, day 3, they're a little bit sleepy, it's too much, you can just take off one of the 5s.
Yeah.
Do you know what I mean? So it's one way you can sort of describe that to your patient and say, we're going to start at this 10 milligram, we're going to start with the 2 5 milligram patches. But if 2 to 3 days' time, if you're nodding off or your husband says you're a bit sleepy, take one of the patches off because you might only need a 5, notwithstanding that most people do need the 10. And the main reason I've now sort of swung to pretty much, not all the time, but the buprenorphine patch is a patch that I use far more than anything else. It's also because there's a difference between the opiates. So that specifically things with hormone levels. So again, this has only really come out in the last 5 to 7 years, that if you go on opiates within quite a short period of time, it drops your testosterone level if you're a boy, or your estrogen, progesterone levels if you're a girl. And we know that long term is not useful either, in terms of bone health, so it increases your risk of osteoporosis. But also, if you're interfering or dropping your sex hormone levels, that might actually make you more sensitive to the pain. So we don't think that's a good thing. So Norspan or buprenorphine is the only opiate out of all of them that doesn't actually reduce those hormone levels. Tapentadol only does it half as bad as like the Oxycontins and the morphine. So there's sort of a range.
But if they've got prostate cancer pain, then you might want to reduce their hormone levels and you might use something else.
You might want to, but on the other side, which is quite significant, all the opiates except for buprenorphine actually negatively or inhibit the natural killer cells. So there's reasonably good evidence out there that say if you've got breast cancer and you go on an opiate, you actually get an increased risk of metastases, except for buprenorphine. So it's the only one that does not increase your risk. Same with prostate cancer. So if I had prostate cancer, not that it's ever going to happen, I probably would not want to be on any of their opiates except for buprenorphine, and I obviously want to be on the non-addictive. But so there's a difference between the opiates, which I don't think we really knew until the last few years. Yeah.
No. When you're seeing, I guess, your average patient with chronic, severe low back pain, I'm thinking, farmers and miners and heavy workers' backs, so they've got no discs, crunchy facet joints, a little bit of nerve root irritation, so some neuropathic pain, some inflammatory pain, some just, general pain. How do you kind of build them up a combination?
Well, pretty much just taking your line, just what you said. So you try to work out which component's neuropathic. So we do this like slump test, so sitting straight leg slump test. So if that's positive and if they've got some of the other descriptors of neuropathic pain, then starting with the antineuropathics would be ideal. So that's more if it's quite a good amount of neuropathic pain. If they've got neuropathic pain as well as like good old muscle pain, doing heavy work pain, then tramadol's a pretty good choice because that does neuropathic pain, inflammatory pain, and nociceptive pain. So those are some of the more simple alternatives. If you actually look at opiates as a group, they actually don't do very well for neuropathic pain.
No.
But if those other ones don't work, then that's an option. And I think there's a big distinction that I'd just like to mention. So in the scenario you gave, the person has got back pain, but they've also got neuropathic pain.
Yeah,
they've got all these other pains. What I like to say is that if people are being referred to tertiary services, or say to people like myself, and if they've been intended to start on an opiate or have been started on an opiate for what we call non-specific low back pain, we'll nearly always suggest to reduce them and stop them, because that's consistent with the guidelines, the European guidelines, but also there's no evidence out there that opiates for common garden back pain with none of those extra components you just said either help the patient in their function, their pain or their life. And there's a lot of evidence that they do a lot of harm. So currently the guidelines do not support opiates for, like non-specific low back pain, so common garden back pain. I think that is different with a person who's got complex pain, and there's different components, but yeah. So your question was, if you have that person who's trying to deal with all those things, what do you do?
What do you chuck into the cake mix?
Yeah, pretty much. So the combination of the antineuropathics, probably the tramadol, Panadol, if it helps, if that gives them a side effect or it doesn't help. And if you were going to try something like a buprenorphine patch, then sometimes if they're having days where they can overdo things, notwithstanding that we try to teach them how to pace their activities, but given that that might happen, there is a tablet called Temgesic, which is a sublingual buprenorphine. Sadly not on the PBS, so it costs about $1 a tablet. But you put it sublingually, it disappears in about 5 minutes. It gets in your bloodstream in about 30 minutes, peaks at about 90 minutes to 2 hours, but it lasts for about 6 to 8 hours. So it's one thing you can use for a breakthrough if you're using the buprenorphine patch. So it's made from the same medication. So again, it doesn't have the negative impact on the hormones or the immune system. So that would be what I would tend to do in that circumstance.
And there's been like a program on the television that a number of my patients have asked me about, in which they said, paracetamol, no use for low back pain, anti-inflammatories, no use for chronic back pain. Go and see your doctor about, the wonder drug for chronic low back pain. I'm presuming...
there isn't one.
No. Because the patients come asking for the wonder drug and I'm going, that'd be good.
So the devil in the detail, and what we haven't spent a lot of time discussing today, is all of the non-pharmacological methods that we use for pain. So right up there at the forefront is the patient learning how to manage or schedule activity, and that's something called pacing, which most pain services is sort of like the pain 101. It's the very first thing we get people to actually do for themselves, and so we run things like pacing sessions, and we've got the Pain Health website, and our WASP website has got information on pacing on both of those two things. The other thing is linking with a good physio who can actually show you how they'll knowledge about how to pace activities, but also show you how to bring on your muscles, like your inner muscles, around the front of your body, transverse abdominis around the back, called multifidus, normally using a bit of ultrasound as feedback for the patient and the physio. But also then if they're overdoing things. So a lot of people with back pain are actually, their external muscles are coming on too tight, like they're too, they're overdoing things. So a lot of the time the physios, it's that balance between, if you're overdoing things, how do we reduce the overactivity of the muscles, as well as then improving, the onset of the other muscles. So the first line treatment really for back pain is a good physiotherapist or a chiropractor who can do similar things, and certainly in the first 4 to 6 weeks there's quite good evidence that manipulation can be useful. So basically going to the non-drug methods for back pain specifically, and not to forget to mention that actually a daily walk, so pacing up slowly. So if you're walking 30 to 40 minutes a day, the daily walk will be more effective than any tablet, probably equally as effective as a physio, and is free. So the daily walk, improves your mood as well, and lots of other benefits. But I think back pain, probably in my management, doesn't equal tablets. It actually equals activity and how we're going to sort of approach that.
Yeah. And is paracetamol really so useless?
Yeah, that's interesting. I did look at that study. That's a study in the Lancet, and it did say that between placebo and Panadol, there was no difference in pain scores. We'll come back to that in a second, because that raises another interesting point about placebo. It also sort of said it didn't change the length of time that the person had the pain for, and that is not surprising to me. I don't see how possibly taking a tablet actually reduces ongoing pain in the future, because I think it's more about what movements you're doing, and if you're doing mindfulness and pacing your activity, that's the thing which reduces the length of the time of the pain. So that doesn't surprise me. It did surprise me a little bit that it doesn't do better than placebo, but also placebo in its own right is actually quite a good painkiller. So at any point that I prescribe any tablet or any activity or whatever I'm discussing, I'll try to tell the patient all the benefits of doing that activity or that pain strategy or that medication, because I know if we can harness the placebo response as well, you get another 30%. So why wouldn't you? So I don't know. I don't know if that study was just the placebo effect is equal to Panadol. So I guess the worst case scenario is, well, it's no better than placebo. The issue in our Western medicine is we haven't found a way to harness that placebo without giving a tablet. I think they have in China and places like that, but we haven't got it yet. Do you know what I mean? So
We could give them homeopathy, I guess.
Well, yeah, and then, are you bothered? So I don't know the answers, what I'm saying, but again, with all of this, when you do a trial, we say, well, let's try this for a few days and see if it makes a difference in pain and if that's sustained. I personally tend to use a lot of Panadol Osteo, so the slow-release Panadol,
Yep.
not straightforward Panamax, and they use Panamax, but I don't think that would make the difference in their study. Yeah.
Yeah. Speaking of complications and long-term medication use, how do you stay on top of the side effects? A lot of patients go, oh, I can't take that much Panadol because it's binding. And I'm guessing that any patient on any kind of opioid analgesic is going to say pretty much the same thing.
Yeah.
And then they get a bit dopey. And
I think the big thing I've probably learned in the last 5 years is that, I know this is going to sound completely corny, but everybody's unique and is an individual, and try to individualise the dosing schedules. And I think where we're going to get to over the next decade is there'll probably be some very clever blood tests genetically putting us into boxes, whether we're fast metabolisers, slow metabolisers, and what that means for drug dosage. And I think that's what we're probably seeing a lot with patients. So if you get somebody who comes in and go, look, I'm sensitive to absolutely everything I've ever get given, I always get a side effect. I mean, some of it, I don't think all of it, but some of that could be that, say for example, it might be rapid metabolisers. So say if you're a rapid metaboliser, so rapid metabolisers are people who take codeine and pretty much, sort of spin out and they get, almost, quite a high euphoric effect. They're also the same people who can drink quite a lot of alcohol and don't seem to get drunk that much. The people who take 50 of tramadol, and that has quite a big impact on them. So the rapid metabolisers, I think, are also the same ones who need lower doses of NDEP, nortriptyline. So I think it's the way we're metabolising drugs. So what I, again, spend a lot of my time is trying to work out for that patient what sort of dosages are going to be appropriate for that person. And I don't have any issues with some people needing quite a low dose and other people needing a moderate dose and other people seem to need a high dose of the non-addictive medications. I don't follow that paradigm through to the addictive medication, so we sort of have this ceiling of about 100 milligrams of morphine, and if that's not working, we either rotate to something else or we just say this is not actually an effective treatment for your pain, so we slowly reduce it by 10% a week and stop it.
so pain medicine, very much like general practice, it's kind of suck it and see.
It is absolutely, so when we go, we will try this, that's literally what we mean. And what we try to do with patients is only try one thing every 4 weeks.
Yeah.
And we normally, nearly with every tablet, we'll go up slowly, see how it works. And if it doesn't work, gives them a side effect, we try to stop it slowly. So start it over a week, a few weeks sort of on what you've estimated to be the therapeutic dose, and then reduce it. But absolutely, be nice to reduce that guessing game, but I don't think we're there yet.
And in terms of the other kinds of side effects, how do you deal with patients who are taking quite a lot of different medications who get terribly constipated?
My bottom line is in the patients I see, nobody wants to swap pain for another side effect. I think pain's not a nice sensation, but you don't really want to swap pain and have pain even if it's slightly reduced and get constipation. So I would tend to look for medications that they can get a positive effect without a side effect, pretty much. And if they're getting a side effect and if they don't get tolerant to it, then I don't think that medication is going to be useful, so I would switch it to something else. And we certainly get some patients who pretty much get a side effect from nearly everything they see. So then I just go, well, for you, medications are not going to be probably part of what you're going to use for your pain management.
I was talking with Dr Majedi earlier about Targin and the combination and using naloxone in the GI tract. I guess it doesn't get absorbed from the GI tract. Is that the reason?
It's better. So I actually don't. The only opiate that I tend to start is the buprenorphine patch, and now if that doesn't work, to Pentatol. Theoretically, the Targin is better because it's supposed to counteract that possibility of constipation, but I think the benefits of the other options are actually higher. So if somebody came in on Targin, I certainly wouldn't take them off it if it was useful and effective. If somebody's on, we almost don't see anybody just on OxyContin, not Targin anymore, and I think that's useful both because there's less constipation, but also because then there's less diversion risk. So I think that's useful. I personally think OxyContin probably shouldn't be allowed to be prescribed at all in this country, but it still is. So, I've sort of swung the other way where and a lot of people with buprenorphine don't seem to get constipated, and Pentatol not overtly as constipating as some of the other opiates,
I was thinking that maybe if naloxone's so effective as an anti-constipation agent, then would it work, say, for the patients who get terribly constipated on tramadol? There isn't just an individual...
It should do, yeah.
And but there isn't an individual oral preparation.
No, there's not. And I have actually asked Mundipharm if they could make one. But yeah, not as yet. But theoretically, the amount of naloxone in the Targan is enough to sop up about 4 times as much of the OxyContin that's in there. So if you're on tramadol and Targan, theoretically it should actually be enough to counterbalance the tramadol if they were getting a constipation effect from that as well.
I've had a question that's distressed me for a while. I've got a couple of patients with ileostomies who also have quite significant chronic pain issues, and for whatever reason they've ended up on slow-release tapentadol. And of course they're showing me their bag in which the tapentadol tablet just goes ping, and I'm thinking, I'm sure you're on such a high dose because you're not absorbing anything. So in that case, switch them across to a patch.
Yeah, and maybe that sublingual... I mean, the good thing about the sublingual buprenorphine is it really does not rely on any gastrointestinal absorption at all.
Yep.
So it's only negative, it's not on the PBS. So when I was at Fremantle, that'd be one of the things I'd probably, like as a non-PBS drug, we'd prioritise prescribing that out of the public system. So that's the only negative about the sublingual, is it's not on the PBS at the moment. Yeah.
Are there any other things that you could use, say, for patients who do have malabsorption syndrome?
But the other thing I was just going to mention is if they had a neuropathic pain component, which, say, if people have got irritable bowel after they've had lots of surgeries, often you find that actually the whole bowel is sensitive, so they may have originally been on pain tablets for something else, but actually now the gut is actually pretty painful. And I find Lyrica, so pregabalin, very good for that. And I think because a lot of those people have had pain for a period of time, so they've more now having that persistent pain, neuropathic pain element, as well as whatever was the initiating factor. And I was just going to mention that Lyrica you can pull apart and it's in sprinkles. So that's another thing that can get absorbed even if you've got a very short gut. Other than that, you're probably limited with things like, Panadol, Elixir. There's Tramadol Elixir, which would get absorbed as well. So what we're trying to avoid in this particular circumstance is giving a tablet and it ending up out in the bag. So basically it's never been absorbed. So I think conversely to most other things, we'd go back to elixirs. So the Tramadol Elixir, Panadol Elixir, opening up the pregabalin and sprinkles, trying the patches and the sublingual.
One of the things that is quite confronting for GPs, I think, is the very demanding patient that comes in and says, they must have this opiate, they must have their oxycodone. It is quite confronting, and quite often they're between you and the door. How do you deal with the kind of, I don't know if you also get the demand patients?
Yeah, we do a little bit. We're in a slightly different spot in that if we're prescribing, we've often started it on that patient. So if we're actually the actual sort of prescribing doctor, we get asked in our role as being a pain specialist sometimes to review other people's patients. So somebody has to start at an opiate, it may not be our one of choice, and then we say, is it appropriate for the pain, yes or no? Is a patient actually improving on it, yes or no? What activities they're doing. So in that situation where they're not our patient and we're just reviewing them, if they ever ask us, oh, by the way, I've just run out of my script and I can't get in to see my doctor till next week and it was due, I just look at them and pretty much, I sort of have an absolute line, which is I just say, well, sadly, we can't prescribe for you because only one doctor or one practice is allowed to prescribe. And if I do, you'll get cut off. So that's just a non-thing. And then nearly always they manage to get in to see their GP to get that script the next day when they said they couldn't possibly get in for a week. So I've just chosen not to go down that line. So me personally, I don't go there. But if you're, let's say, a GP in a practice, then what I'm hoping is with all your clever software, if another GP in your practice has been prescribing, then they've got like the authority. You should be able to, and let's say they're away on holiday, so you should be able to get in there and find out, the last script, is it appropriate, and basically have a history. And I think if every practice, if that's not the case, so they're not from that practice and they're not, you can't check. Sadly, I think the state health line and the doctor shopper line, they're a little bit behind, so it's not. I mean, I do often check that, but it doesn't really help you today. But
no.
So therefore,
and it certainly wouldn't help you while the patient's in the room to ring up a doctor shopper line if they're looking a bit aggressive.
But the thing is, if you can't see it on your computer or from your practice, it's not normally prescribed from that practice, and then I would just decline. And you decline on the basis that if you do this and you're not meeting your guidelines as a doctor, and also the guidelines of the state health is only one practice or one doctor should prescribe, so they need to go back to their previous, whoever's started it or whoever's supposed to be prescribing it. And I think we can do that quite, that's quite a solid line now. I don't think that's a negotiation line.
Yep.
And then if they say, oh, well, that doctor won't see me anymore, whatever, they say, well, I'm really sorry, but until, this is not we're not going to solve this today. This is something that needs to be organised.
Mm-hmm.
But mostly when that happens, you find that they are going to multiple practices. Not all the time, but often, it's a real red flag.
Yep.
Yep.
And if you do think that they are just getting their medications to resell or recreate with?
I stopped a really long time ago trying to work out who was doing what with medications, because I found that as a professional person, if somebody came in really well dressed and spoke to me really nicely, I would have, say, more than a decade ago, assumed that they weren't doing anything funny with the medications. I don't think that at all anymore, so I pretty much follow the same line. So basically, if it's an appropriate thing to try an opiate and they're doing all the right things and they're actively involved in their own management, and it's appropriate to try an opiate, not despite what they look like, but I try not to judge based on postcode or what they're wearing. And so therefore you do a trial. And the good thing, going back to the buprenorphine patches, is basically it's not easy to inadvertently take a double dose. So say if you're giving tablets, someone goes, oh, you're giving my script for 20 tablets, but I've used them all in 5 days, and now, they work really well, but now if I don't have them, I'm going to have withdrawals. The thing about a patch is you can't suddenly inadvertently slap 2 patches on and not recognise it. So that's one advantage of the patch. They can't escalate the dose. And say if there's a past history of IV drug use, which there used to be for quite a lot of the patients who saw at Fremantle, then I'd put them on what's called weekly observed disposal. So basically on the script you write down, must return the patch prior to the next one being dispensed, because that Norseman patch has got about 70% of the stuff in the matrix when it's finished with. I'm sure there's ways to extract that. But if they've got to take the patch back to the pharmacist for the pharmacy to put in their safe disposal thing before they get the next patch, do you know what I mean? Then there's less lying around. Mm-hmm. And the other thing, if you've got patients who, they're not on a patch, they're on tapentadol, but they're coming in early, you can put them on the script. You can say, please dispense X number of tablets every 3 days. So it'd be 6 tablets every 3 days. So you put them on short dispensing. Mm-hmm. But I think as a community,
it's quite useful in a small country town. You can actually do that.
You can do that, yeah. And most pharmacists, we don't ask them to do that very often. Most people will only charge that one-off dispensing fee when they fill the script, but then the patient's got to go in. And I've really, to their credit, never had any pharmacist having an issue with that. And I think the more that we can go to the least avertible, least harmful options, like the Norseman patches and tapentadol, where the overdose risk of death is mm-hmm. much less, I think we're just going to be helping the whole society. I think we also have to just start, we're not going to get bullied into giving scripts if we don't think it's the right thing.
Yeah. And how harmful are these opiates?
So I became aware a few years ago that, say, for example, in the United States, it was in 2008 when the risk of death from prescription opiates actually exceeded the risk of dying in a car accident. This is in the United States.
Prescription opiates, not just
prescription
all opiates.
Yeah, no prescription opiates. So we sort of knew that, and I've sort of you can get WA data off one of the health websites, which I've been doing, and in the 5-year period, 2007 to 2011, it was about 2/3 of the deaths of car accidents were attributable to, actually in this thing, opiates or combination of opiates with something else. And that was something else, alcohol or benzodiazepines. Mm-hmm. Okay, but I've been told since then, I haven't got the data, but I've been told that we've now crossed the line. So in Australia, more people get killed by prescription opiates than get killed by car accidents. And I think that's pretty significant.
Pretty scary statistic.
Pretty scary statistic. And now that's death. So death is bad, we all agree that. It certainly makes rehabilitation a lot harder. But the other part of that is ED admissions and inpatient admissions, and that's quite high. So it's not a small thing. Yep. And I think, go back to what I said at the beginning, 20 years ago we didn't have a lot of other options, and I really don't think we did. And we didn't have this knowledge that we did think that if you're on an addictive substance you wouldn't get used to it. Well, that's clearly wrong, and it's sort of, now that you think about it, why did we ever think that? But we did think that. But now we're in this different place, we have different options, we've got safer tablets, we've got non-pharmacological options. We've actually got, I think some opiates are safer than the others. I don't think there's much difference in how likely it is to have the pain. I think they all look very similar, but there's different side effect profiles. And there's certainly a range of which ones are more likely to be divertible and cause death versus other ones. And I think tapentadol's killed 1 person in Australia so far. I'm not sure if Norspan has it all, whereas the death rate with things like the OxyContin is actually quite significantly higher, especially when it's not combined with naloxone or it's not the tamper-free formulation.
Yeah.
So, you know, we can sort of choose.
I'm anticipating that to die of Norspan patches, you'd have to stick an awful
inadvertently,
lot.
that's right. I'm aware of one lady had a 100 fentanyl patch and had put a water bottle over the top. So there was an issue with heat on top of a high dose patch. But yeah.
Finally, Steph, the patients are frightened of being back in pain. But say you want to step down their opiate. How do you go about that?
Okay, it's actually not difficult. I spend quite a lot of my time writing how to do it, like in letters. But the gist really is just like organising activities. So when you're doing a daily walk, you go up by, you count how much you can walk without a big pain flare. Do it at the same level every day for a week. Then you go up by 10% a week. The body can't pick going up by 10% a week, and people don't get pain flares. Same with opiates. So if you go down by 10% a week, so you just work out the opiate dose you're on now, and I normally work back to morphine equivalents. So this is how much morphine you're getting on a daily basis now. So next week we go down by 10%, do that for the whole week. The next week down by 10%. So you just go down really slowly. Some people go 5%, some will go 10% every fortnight. I just tend to go 10% a week, and I would adjust if needed, but that's rarely necessary. And what that means is they don't get a pain flare and they definitely don't get withdrawal. So if you didn't have pain and you're just on opiates, you can reduce the dose by about 50% a day and not get a withdrawal. But if you've got pain, odds on you get a big pain flare. So the going down by 10% a week is a really safe way. It's also very mathematically easy. Obviously you might have to round up, round down a little bit, if it comes out to 67 milligrams or something, but so it's easy. The other thing is if people are on an opiate and say they're on something that is working becomes less effective, is opiate rotation, which is quite a good thing, so that it's a bit like if you're on an antibiotic for, you've got a chest infection and it hasn't cleared and you go and see the GP, they give you an antibiotic and a week later you're still unwell, or say even, 4 to 5 days later, the GP wouldn't normally just keep escalating your dose of that antibiotic. They go, probably not sensitive to that, let's swap it to something else. Same with opiates. So whether it's tolerance or just non-opiate sensitive pain, if one thing is not working, don't go down the thing of just increasing it. Work out the morphine equivalents and switch to something else. So the opiate rotation is a good trick.
And how do you work out morphine equivalents?
Okay, so if I speak really slowly, roughly, 100 of morphine is equal to about 50 of OxyContin. Okay, which is
100 of morphine.
Yeah,
is 50 of OxyContin.
Yeah.
Right. So the stuff is really very powerful.
Yeah, and some people say some people say it might be between 50 and 70 of OxyContin, but I always do that conversion. 100 of morphine is 50 of oxycodone, I should say, and that always seems to work. Like I've never had any issues with that, conversion rate. With buprenorphine, so the 20 patch, which is the highest patch, that's equal to about 90 of morphine. So your highest patch of Norspan is slightly below that 100 milligrams of morphine a day. Hydromorphone and methadone, it's 20 is equal to 100 of morphine. So 20 of Genista or 20 of methadone is about equal to 100 of morphine. And tapentadol, it's 250, is about 100 of morphine in terms of analgesia. I know that the company that's making tapentadol seems to be wanting to push higher doses, but in my opinion, that just gives people more side effects, and it's not really the most useful thing. I think if people aren't getting an adequate analgesic at a reasonable dose, just escalating just tends to give people more side effects for not a lot of extra benefit. Yeah. So then with the only trick in any of that is if you're swapping people onto Norspan patches, then you give them a script, say in the afternoon, say go and get them from the chemist, stick them in your cupboard at home, and then in the morning put the Norspan patch on, take your dose, your morning dose of your oral tablet, whatever that might be. But then that's the end of it. You have no more of those orals because the Norspan patch within about say 8 to 10 to 12 hours is working pretty reasonably. So by the evening, it's got to about 60 to 70% of its dose. Do you know what I mean? But that when you first put it on, you take your normal oral dose in the morning. Yeah.
And is there a nice, easily accessible table on the internet or something where you can actually get morphine dose equivalents?
Actually, you can. I've got one on a slide, which I have emailed to lots of people. But pretty much if you get onto Google and go opiate conversion calculator, there's one by something called RPH. It's actually in the US. It's not RPH. It's not Royal Perth here. But I've used that one on quite a few occasions, and the conversions seem accurate. So if you just Google opiate conversion calculator, it comes up with a lot. But about the third one down is RPH, which is the one I tend to use.
Stephanie, any final take-home messages for the doctors?
Just, I think we need to move off the square of thinking pain equals opiates. I think we should be thinking, somebody's got pain, what is it we can change about their activity? Do we really need to get them more advice on like mindfulness, which is, you know, quite trendy at the moment. I think most people know about mindfulness. There's a really good app called Buddhify, which is $6, and they've got all these different mindfulness apps. You know, getting a good physio, good OT, and if they've got high stress, high anxiety, high worry, get a Clincycin. But also from ourselves as a doctor, don't buy into that, you know, the over, I'm going to call it catastrophization, even though I hate that word, but, you know, don't buy into the, you know, the high level stress, anxiety, fear and worry. At the same point about making sure there's nothing we're missing. So we have a pretty hard job, I think. We've got to be reassuring, but also at the same point making sure we make a diagnosis and look at all the different components, so it's tricky.
And are there any online resources or other things that rural patients can access, given that trying to get to STEPS programs and things is quite difficult?
Well, we launched something called the Pain Health website in April 2013. We've tried to put everything that we know, nearly everything, not absolutely everything, but everything on that website. It's got, so if you just stick in Google Pain Health, because it's got quite a long thing, so Pain Health, all one word, it comes up to the Pain Health website. And then if you go to Pain Management Learn More, under the pictures of the people with the videos, there's actually about 10 different modules. And I say to patients, if I'm going to get them to do that, I say try and do one module a week. You can't possibly do it all in a day. You know, they're quite big modules. And that's got information on mindfulness, pacing, movement. It's really quite a lot of information. That's like the longest durable pain on our website that we set up for this practice, which is WASP-pain. In the top right-hand corner, we've got some cartoon characters with examples of pacing and just links out to Pain Health. That's like the short story. And we're also this year just finishing writing a book called Rewire Your Pain, which we've aimed for, you know, 12-year-olds and older. And it's just finishing the illustrations, and we've been trialling that for our patients, and I think they've, here finding it really useful, and also because then they can give the book to their partner to read. And that pretty much is only 2 pages on medication, all the rest is on everything else. And we're hoping you're going to do a web app for pain, which will actually help doctors and patients, you know, work all these things out, like which things are useful, which things aren't, but we're not there yet. We haven't done it yet.
So watch this space.
Watch this space, give us a few months, yeah.
Well, that's all we have time for in this program. There are some really good links and resources relating to opioids on the Rural Health West website that look at the current thinking in the management of chronic pain, guidelines for prescribing opioids and treatment options for addiction. So please visit the Rural Health West website, ruralhealthwest.com.au, and take a look at some of those resources. Thanks again to all our guests, and thank you for joining us. See you next time.